Hello, and welcome to the Sentinel Innovation Methods Seminar Series. My name is Rishi Desai. I'm an associate professor of medicine at Harvard Medical School and epidemiologist in the Division of Pharmacoepi at Brigham and Women's Hospital, and I will be moderating today's session. The US FDA Sentinel system helps address questions related to safety and effectiveness of marketed medical products, and the Innovation Center focuses on developing innovative methods to further advance Sentinel by leveraging new data sources, building new tools, and enhancing real-world evidence capabilities. We launched this webinar series to engage with experts and innovators in key areas related to Innovation Center's master plan and Operation Center's methods work. With that, I'm really pleased to introduce today's panel. So we have two speakers, first of whom is Dr. Anjum Khurshid. Dr. Khurshid is an associate professor of Harvard Medical School and the Harvard Pilgrim Healthcare Institute. He's also the chief data scientist at the Sentinel's Operations Center. Dr. Khurshid was previously co-chief Health Informatics, Data Science, and Epidemiology Division at Department of Population Health and associate professor at Dell Medical School at UT Austin. He has served on the United States Federal Advisory Committee for Health Information Technology, and he was also a patient engagement advisor to the PIC body. He's a fellow of the American Medical Informatics Association and is on the editorial board of Blockchain in Health Today. Dr. Khurshid has years of experience working with electronic health records data and substantial experience, especially with the health information exchanges. Now, second speaker is Dr. David Kendrick. Dr. Kendrick is the founder and CEO of My Health Access Network, Oklahoma's health data utility and state-designated entity for health information exchange. Dr. Kendrick also founded and chairs the Department of Medical Informatics at University of Oklahoma and serves as an assistant provost for strategic planning at the OU Health Science Center. He's the immediate past chair and current member of the board of the National Committee of Quality Assurance and CQA and serves on the boards of Civitas Network and the Patient Centered Data Home. He serves as a senior counsel for interoperability at the Office of the National Coordinator for Health IT, co-authoring the nation's 10-year roadmap for interoperability. So clearly, the two experts that we have invited today and who have kindly agreed to speak have years of experience collectively on health information exchanges, and we are really keen to learn from their expertise on this topic. And this really represents an area of keen interest for the Sentinel program because we are always looking for data sources that can help advance the mission for Sentinel. And so the title for the presentation today is Regional Health Information Exchanges as Critical National Infrastructure, Supporting Federal Agencies' Missions. So before we get started, I would like to mention that your lines are muted. If you'd like to pose a question, please type it into Zoom Q&A. We will answer the questions at the end. Finally, the session is being recorded and will be made available to our webpage, which is sentinelinitiative.org. So without further ado, I'll first hand it over to Dr. Khurshid, and then he will hand it over to Dr. Kendrick.
Thank you. Hello, everyone. And thank you, Rishi, for the kind introduction. Also, thank you to the Sentinel team at FDA for providing us the opportunity to present on this emerging topic of the importance of health information exchanges as a source of comprehensive data. I'm also very pleased to have Dr. David Kendrick with me co-presenting. And so just a disclaimer that most of the work that we will be presenting here is an overview of HIEs as a source of data based on our experiences and our work. But we will also be presenting some information towards the end of this presentation that is work done through a task order under Sentinel. So all the views, however, that are expressed here are of the presenters and do not represent FDA or our respective organizations' views. So next. And so overall, our plan is to be able to talk about HIEs just as an introduction to those who may not know the details of how they have evolved over a period of time, what is their coverage, and why we think that they are a unique data source to be considered nationally. We will then explore their evolving role as health data utilities, and then move from the conceptual to the real-world setting, where Dr. Kendrick will further demonstrate with data from the HDU that he has established over many years, the opportunity that we have in building a better infrastructure for health data. And then we'll also talk briefly about an exploratory study to translate this potential into the kind of questions that FDA or other pharmacoepi researchers might be interested in. Next. So let's begin by introducing the concept of health information exchanges as it has developed in the last 2 or 3 decades. Next. So really, after the massive digitization of clinical records, when we moved from paper records to electronic medical records through generous investments from the federal government in the HITECH Act in 2009, the electronic medical record adoption in the US jumped from 33% to almost 85% over a period of 5 years, which was very rapid. However, the ability of EHRs to exchange data with each other seamlessly turned out to be a bigger challenge than we had expected. So the federal government and several regional collaboratives then put in place a platform or an organization that could simplify these many-to-many data exchange issues by acting as a hub that allows for bidirectional connectivity from all healthcare providers, thus reducing the number of interfaces that needed to be developed and maintained. And these organizations were usually nonprofit or not-for-profit entities with local governance and engaging healthcare providers in a certain geography. And so these health information exchanges then had to also develop then ability to be able to use standard data, be able to manage role-based access in order to protect both security as well as privacy of the data, create auditability of these records or the use of these records, and promote interoperability in a certain geography, in a seamless way. Next slide. And this regional strategy then could translate into a kind of national infrastructure for a learning health system, which is based on this interoperability. However, as you would see, that this also requires local trust, local governance, and then engagement of patients and providers in meaningful ways in order to establish that learning health systems that we have been talking about or would want to establish in the country nationally. Next. So in terms of what data elements are available in health information exchanges, they obviously depend quite a bit in terms of geography and the healthcare ecosystem of various states across the country. However, one of the things that has been very positive is that there was a move to develop these US core data for interoperability standards, which is a set of health data categories and data elements that have been defined in detail by the Office of National Coordinator of Health IT in collaboration with industry and other stakeholders, and has now been mandated for electronic health record certification and also indirectly then to HIEs. The below visual, because there's variability, but at least whenever data are shared across these data elements that you see on your screen, which define some of the common data that is shared, these data are defined in detail and have been agreed to by industry in terms of how electronic health records will be transporting and saving this data. So this is a very elaborate system of standardizing this. It is continually updated, and as the federal government and the industry identifies needs for additional data to be added to this core data set, those are then defined, and there is a whole process federally of approving those as a requirement for certification. So just for your information, currently we are in the version 2, but there is a version 3 that has already been approved, which will be applicable from 2026. And there is a version 5 actually in discussion, which has 16 other categories of data that will be included in order to enrich this data set. So What is important to understand here is that there is a national effort to standardize data that is stored in electronic health records, which is part of the certification requirements, and that data then gets collected or transferred to health information exchanges in the same formats. Next slide. So once HIEs have all this data, then they can provide multiple services or different types of services to those who are contributing their data and those who want to use this data. The primary use case, though, has been mainly exchange of information or interoperability, so that coordination of care can take place across various providers. And as you observe here, this is just an example from a recent survey that was conducted by through ONC by UCSF, University of California, San Francisco, and Civitas, which is the HIE Association, and shows where HIEs have indicated the kinds of services they are providing, and most of them are providing alerts and notifications across these systems. But then, as you also see, that there are others that are providing prescription orders and fill status for medications, as well as almost 40% that integrate some claims data with their EHR data as well. There are other interesting details here as well, which some HIEs do, but that's, again, I think there's more information that is available on this slide. Next. And then, while in a region, health information exchange plays a pivotal role in making sure that patient data are exchanged seamlessly across different providers, because we know that there's fragmentation of that patient data. But there is also now a network of these health information exchanges all over the country. So, and as I mentioned, the recent survey showed that there are almost over 80 health information exchanges, and most states, almost all states actually, have at least one health information exchange. And many of these health information exchanges cover the entire state, although there are larger states like California, New York, and Texas that have multiple HIEs that are also established. But this is a fairly impressive coverage, and in some ways they cover almost all parts of the country, which is a unique opportunity for us to think of how does this nationwide health information exchange serve some of the needs of getting nationally representative data for not only exchange of information, but also for surveillance and research. Next. And one of the efforts then that has been underway, and Dr. Kendrick has been leading it for a long time nationally. It's a very unique effort in terms of being able to push data of the residents of the patient whose data are captured in other areas. So the system is called Patient-Centered Data Home, and the idea is that if a patient who lives in New York, and most of their data obviously will be in the New York HIE where the encounters happen, but if they're traveling to California and have an encounter there, then the California HIE will use the Patient-Centered Data Home technology and technology platform to identify the home of that patient's, the home HIE for that patient, and be able to push that record to the New York HIE so that the patient's records are always complete, irrespective of wherever their encounters are taking place. So collectively, this network, as you can see, covers almost all zip codes in the country and allows for a comprehensive clinical record to be created, which is in contrast to a lot of other efforts where it is more about pull, where you have to request for data from multiple sources, while in this case, it actually creates this complete record without extra effort from either the patients or the providers in terms of getting that information completed. Next. And so what is unique about the health information exchange data in some ways is the nature of the creation of these nonprofit entities in the community and their role, where almost all HIEs include data from uninsured, underinsured patients, something that is not always available in large data sets, where data may be collected because of insurance status or some other criteria. And that is very important for really thinking of health equity studies and understanding that. And for pharmacy fill, as well as data from inpatient labs, etc., especially as many patients are also paying out of pocket for prescriptions, sometimes that information is also available in HIEs. And then most HIEs also cover rural areas because that was part of the requirement of early federal funding. So that's also a unique aspect of the data that is available in these HIEs. And the HIEs that also, because they hold data on behalf of the original data sources, one does not, if one was looking at bulk data or large amounts of data for either epidemiological studies or large studies or population health studies, then one does not have to deal with individual health IT systems or legal systems or legal teams in order to get that data, which is, if any of us have dealt with that, we know that it is very time consuming and costly. So in some ways, it makes it very efficient to be able to access data. But these data are shared according to written policies and written agreements between HIEs and the data sources, and a governance structure that is very local. So in addition to that, many HIEs also connect to or link to images or directly to pharmacies, and they are increasingly also connecting to long-term care. Again, that's an expansion that is happening. Many are getting data from state-level registries, and many are contributing to state-level registries, and in some states, they are also hosting some of these registries. And the final part, I will say, which is also very unique, especially as we look at richer sources of data, is also not just structured data, but unstructured data that is available in clinical notes in many HIEs. And because of their local relationship with the original contributors of data, they also can allow access to patient-level charts and these details if needed for various studies. So all those are, I think, unique aspects of HIEs as a data source to be considered when we are thinking of doing large studies or also trying to understand trends in various communities across the country. Next. And although HIEs actually do not appear as much in the literature, in the published literature, as they should be, I think, but it's partly because, as I'd mentioned, their focus has mostly been on care coordination as the primary use case. And also because they do not necessarily advertise their services for commercial purposes. So the incentives are low there. But they're increasingly being tapped for studying diseases and utilization of healthcare. Was particularly important during COVID, when people realized that there aren't any centralized places to look for population level data. So that's something that will be increasing in the future, we hope. Next slide. And so, as we have learned again through evidence and other studies, increasingly that patient and population health outcomes are to a large part determined by factors that are outside the controlled clinical services or clinical environments in which we provide healthcare. And these are socioeconomic factors, environmental factors, and other factors that not only impact those outcomes, but also impact access to care and some of the other aspects that lead to more inequities in health. So one of the things that has also happened is that most HIEs are now transitioning into a role that is broader and wider than it was initially considered, because there is a demand for getting data from these other factors that affect these outcomes. So which means that health information exchanges are not just healthcare information related exchanges, but they actually become a utility. And this concept of like many states have now designated their health information exchanges as health data utilities, where like an electric grid, They generate data for multiple users, and then users can run various gadgets or run factories with services being provided by this centralized utility that stores the data, cleans up the data, and makes it available according to whatever rules and regulations are available. So that's a very interesting concept because it broadens the comprehensiveness of the data that is being collected. And next slide. And the key aspect of that is that the data are actually more focused on the patient and families than it is about just organizations. So Maryland was actually the first state that that legislated and declared its state HIE to be a health data utility. Although I think there were many HIEs that were organically kind of working as a health data utility because of the needs of their local population. Or just following a more comprehensive strategy to promote care and wellness in their population. So because that requires not only coordinating care in medical settings, but also then getting social services, education, housing, nutrition, and environmental data, and partnering with these agencies across the spectrum that reach the same person and the same family in different sectors. So that fragmentation, to address that fragmentation, as you see in this comparison, health data utilities have expanded in terms of their governance, expanded in terms of the data that they have, expanded in terms of the use cases that they are now supporting, which go beyond just healthcare coordination and epidemiology to really thinking of issues like food insecurity and housing challenges, et cetera, that affect healthcare outcomes. And the stakeholders have expanded, but it also becomes a little more complicated because there are more laws and rules and regulations that have to be applicable. But we are increasingly seeing the use of these health data utilities now for addressing really actionable problems like how do you create value-based care? How do you have population health strategies? While those are some of the primary use cases that are developed, but as you can see, it creates a very rich secondary use of that data for surveillance, public health, and population health. So next slide. And this is just hot off the press. This was just published last week in the New England Journal of Medicine artificial intelligence thing that as we move in this future where we develop AI models for healthcare, HIEs evolving into health data utilities can play an important role in ensuring that we are taking equity into consideration by providing more representative data and facilitating local patient and provider engagement and building trust in these models. And so this paper basically offers, along with my co-authors, we offer a policy recommendation to consider the unique role that HIs and HDUs can play in supporting the future development and evaluation of responsible AI applications. With that, this is kind of the background, but with that, we'll transition into really thinking about or exposing you to the real world setting of a health data utility that David has been managing. So over to you, David.
Thanks, Anjum. I'm really pleased to be here with you today to describe a specific health data utility. Began life as a health information exchange in 2009 called My Health Access Network. My Health is based in Oklahoma and serves the people of Oklahoma. More than 2,200 locations statewide, about 130,000 patient visits a day come into that system, so quite a high data volume. My Health is like most health information exchange, health data utilities, we're a nonprofit organization and now have more than 5 million individuals with 12 years approximately of clinical history, some going back much further, 12 years of claims data, and 6 years of detailed social determinants of health data. You can see here on the map the different shapes and colors represent a wide range of different types of clinical organizations that run the gamut of stakeholders in healthcare. But we also know that patients often get care from home, and we have evidence of that in our master person index, which shows that roughly 80% of all U.S. zip codes have someone in them who've received care in an Oklahoma-based facility at some point in the last several years. And so we also have to address this boundary condition in order to ensure the health records stay intact. And Dr. Khurshid was talking about the patient-centered data home, which is our primary tool in ensuring that that medical record stays intact. But when we transition to health data utility, the concept of health data utilities, we're really looking for the ability to provide the most comprehensive information we can about each individual so that it can be there when and where they need it for decisions about their care, the services they may need, etc. And so at this point, the primary data sources we're working with are clinical, as we've been talking about, but also claims and cost or attribution data, and then social determinants of health information. So what's not always obvious, I think, unless you're actually providing care to patients in multiple organizations, is how fragmented it is. What this chart shows is that claims data, we like to say, is a mile wide, but only an inch deep, because it does have most diagnoses and procedures, because those are charged for, but it doesn't have vital signs and lab results and other critical events in the information. On the other hand, each of those EHR columns, which are separate clinics or separate health systems, are a mile deep but only an inch wide, because as you can see, real patients tend to have data in multiple places, as I'll show you in a moment. And unfortunately, the sicker the patient is, that is, the more health complications they have, the more places they're likely to have data, because they're seeing more specialists, more providers, having more ER visits, and so forth. So there becomes a real imperative for us to be able to assemble the health record in this complete form, as you see it on screen here. Furthermore, even the claims data sets are fragmented. As we know, about 20% of commercially insured individuals change insurance every year, in which they are essentially die in one data set and are born again in another data set, which presents its own interoperability challenges that CMS has tried to address with recent policy. And so, as a health data utility, we take this as central to our mission, organizing this view of each individual so that when they receive care, when the decisions need to be made about their care or services, that they can be viewed as a whole person rather than whatever part happened to have walked into or experienced a particular clinical site. And so here are the real numbers behind that fragmentation in Oklahoma. And this chart bears some explanation. So on the x-axis there at the bottom are numbers ranging from 1 to 34. That's the number of locations patients have data, number of other locations that patients have data. And on the y-axis, you see the 5 largest health systems in Oklahoma. These are all large comprehensive health systems with, obviously hospitals and clinics and urgent cares and the full gamut of services. And what you can see in this chart is that, for example, the 6th column there, that health system E has 18% of the patients it takes care of have data in it in 6 other places across the community, meaning the records on those patients are fragmented into 6 other locations as well. And so for our purposes of trying to do good science or to deliver comprehensive high quality care, we really just most need to understand this first column, because this column is essentially what percent of patients those health systems take care of that only have data in that health system. That is, what is the chance that something important about this patient might exist in other places in the corollary? And you can see that there's as much as little as a 92% chance and as much as a 99.5% chance that I need to look at records in other places for every patient that walks in the door in any one of these health systems. So that's often an eye-opening statistic, because speaking as a healthcare provider myself, it's often overwhelming already to be looking at the data in the EHR in front of me without thinking about the amount of information or key events that might exist in other places. And so this is a role that the health data utility fills. And this is corroborated by the medical literature. My FAM showed in an NEJM article in 2007 that the average primary care provider is tasked with coordinating care with 225 other providers in 117 other organizations. So extrapolate that now to the need to do good science, to meet the mission of Sentinel. It makes it a very difficult task to have all the data in one place in order to sufficiently answer these research questions. So we're often told then, well, this is the reason we chose our particular EHR vendor, because lots of our peers, our other organizations also use that EHR vendor. And therefore, if I choose vendor A, I'm already going to have access through their internal proprietary network to all the other data I need. So we slice the data that way by EHR vendor in Oklahoma. Same x-axis there with the number of locations of data. But the y-axis now is the top or the 6 largest or most deployed EHR vendors in Oklahoma. And what we see are very similar numbers in that one column. There's, once again, very high likelihood that I'm going to need data from patients from other EHR vendors on this patient. And this, of course, is assuming it were even true that I could get all the data from a particular vendor, which is not really possible. So we have to keep this in mind as well. That you know, independent of vendors, independent of locations of care, patients are going to have records in multiple places. Now, if we look at it from the patient's perspective, this is how fragmentation of health data occurs by age group over time. And you can see, which is probably pretty obvious, that fragmentation increases as we age because we get more illnesses, we see more providers, our records are in more locations. But also, and I think this is one of the most important things to point out here, you can see that there's no time in a person's life where there's not fragmentation of their data. You can see even there at the young age of 0 to 4, there on the far left, that on average, medical records exist in 3 places. So interoperability and the need to have access to the complete health record on an individual, regardless of use case, whether it's coordinating care, or public health alerting and reporting, or doing science, one must have complete data to do this with. So this is a sort of a snapshot of a demo patient in the system that we operate at MyHealth. And what it shows is a single patient's record with data from as many as 30 more or more places, as you saw in the other chart. All aggregated into one picture for the patient. And what's unique about this is that rather than individual documents, some of you may know of something called continuity of care documents that are essentially a summary of the patient's record from one organization. Rather than having to read those multiple documents as a healthcare provider, the MyHealth system digests those records into a single common FHIR repository for that patient's record, so that I can see one list of medications, one universal list of allergies, vital signs, lab results, etc. On this patient, making care delivery more efficient, but also enabling a lot better use of the data for secondary purposes like care gaps and alerting and public health and others like this use case today. In addition, this is the new required standard for data to be stored in for interoperability. It's called FHIR, Fast Healthcare Interoperability Resources. It's a JSON-based data structure and is very well enabled for application programming interface access as well. So really moves with one step. MyHealth has moved all providers in the state of Oklahoma up to this interoperability standard. But there's more than just clinical data, as we've discussed and as Anjum discussed, that's necessary here. And so this is a similar picture to the clinical data, but one focused on the social determinants of health. And it's very likely that anybody who might need the services of a food pantry or housing may also need services from other types of social service agencies. And so it's also important that we as health data utilities are focused on helping to gather and even screening for, as you'll see in a moment, these kinds of events, so that we can anneal this data with the health record and make sure that it travels with the patient so that they get comprehensive, appropriate services where and when they need them. So at MyHealth, we offer a social needs screening platform that's triggered when patients register for care. And we've been running this program since 2018. I'm happy to say, since it's mobile device based, that it was COVID proof and worked even through the telemedicine days. These are numbers through May of 2024. I'm happy to say that we just crested 4.8 million offers to screen to patients, with over 1 million responses to these social needs. And one of the things about the way our program works is as soon as a patient reports a need, they are also offered 3 options for referrals: food pantries, housing units nearby, all within walking distance or close proximity to where they are. So finally, on sort of our core work as health data utilities, we really are focused on preserving the chain of evidence with this data, because we know that whatever the use case is at the other end by our providers in the community or others, it has to be high quality, accurate data. It needs to be deduplicated. It needs to be standards based and so forth. And so this chart just shows our chain of evidence, beginning with data entry on the left-hand side with a provider in practice, or whatever the endpoint is that's supplying the data. And then the vendor itself, the local vendor, in this case, an electronic health record system, where they map the data from those fields that the data is entered into standard document types like continuity of care documents or other HL7 message types. And then that data is transported to us, where we take over and handle all of these other steps in the process. We transform the data, we organize it into a central data repository. I mentioned the FHIR data repository we have for this, and we do code normalization to clean it up. And the call outs at the top are all just sort of examples of all the things that can go wrong that we have to monitor in this. And we provide this service as the health data utility, so that whatever is made of the data on the other end is based on true and accurate data to the best of our abilities. All right, so we were approached at MyHealth by the Sentinel team to consider taking on a project to explore the potential incremental value of using health information exchanges, and notably those at health data utility level status, to support the mission of Sentinel in its work with protecting Americans' health, especially when it comes to devices and medications in circulation. And so our exercise was basically to do this. This was a study design. And the first thing that we had to do, and I can't emphasize this enough, and Anjum spoke about it as well, governance of the over the data really undergirds everything we would do. You know, unlike federal agencies, which sort of come from the top down with their work, and appropriately so, we as community-based networks have grown up from the grassroots, and therefore derive our ability to exchange and transfer data from the trust and permission granted by the individual communities that we serve. And in Oklahoma, that it includes not just the general rank and file patients in hospitals and clinics and others, but also the tribal health systems that participate, the other agencies, state government, and so on that participate as well. And so our governance over sort of as an umbrella over that, and they weighed in on this proposal of this study design that I'm going to show you, and ultimately approved the use of the data in the MyHealth system for this purpose. And that's very important to obtain because, as you may know, privacy laws, rules around the secondary uses of health data, notification of patients, and so on, can be unique from state to state. And so one of the strongest features of having a network of health data utilities across the nation is that each of us know and understand our local rules and policies very well, and are in the best position to make sure the data gets used appropriately in this way, and therefore serve as sort of the ombudsmans or the relationship managers from these federal agencies into the state. So the first element of the design of the study was to include patients with type 2 diabetes, include patients with some EHR activity, and exclude patients with type 1 diabetes from the program. There were no strict insurance eligibility requirements, and as you've heard, you know, our networks are focused around people with belly buttons, not people with a particular insurance, which I think is a real strength of this model and approach. And we use standardized value sets to assess patient characteristics, you know, NDC codes, ICD-9 and 10 codes, RX norm codes, LOINC, CPT codes, etc., to ensure that we were pulling standardized data from across more than 50 different electronic health record systems that we take in on a daily basis into our systems. And so the timeline of the study was to identify a study entry point, or kind of a born-on date, into this cohort as being the date that the patient was first exposed to prescribed SGLT2s and DPP4 medications of the class like Ozempic and these other sort of miracle weight loss drugs we hear about these days, but have really been around for a while, many of them for treatment of diabetes. And we were able to stratify this across a number of age groups, genders, and all races and ethnicities. And the look at this data was basically, you can see here how this broke down. Very quickly, we were able to identify on the DPP4 arm of this over 76,000 patients that qualified into the cohort. And you can see the numbers there that were over 60,000 we had clinical EHR data on, and almost 16,000 we had claims data on. In the other arm for SGLT2s, we had over 100,000 patients that qualified into the cohort, and the EHR data was available on 84,000 of those, with claims data on 17,000 of them. And so I think this is interesting to look at, but the more interesting view of this data, and really more important view if you want to perform science with good methodologies, is to understand that claims data and clinical data often count the same patients, and that there's a real risk of duplication of individuals if you're not careful and don't have an overall master person index. So here, for example, is the way the population in the DPP4 broke down. You see there the 76,000 patients, and so here represents payer 1, payer 2, and payer 3. So we had 3 sets of payer information. And the first thing you'll notice is that those payers indeed overlapped. And in fact, there's an intersection point where a set of patients existed at one time or another in all 3 payer data sets. And this is important to recognize. And so you can see here the relative percentages of those populations. And then if we layer on top of that the clinical data set that's also in the same system, and you can see this, what we just call it EHR data, but it's really data from, as I said, more than 50 different EHR vendors from more than 300 different organizations who supply that data on a real-time basis into the health data utility. And you can see that 63% of the individuals included in the study didn't even appear in either claims, in any of the 3 claims data sets. And so let me just fill this in so you can see, as we start to look at the overlapping parts, this is really, to me, was a very enlightening way to look at this data, because really we should be looking at the longitudinal, as much as possible, story on individuals and the most comprehensive data possible. This shows what might have been ignored in the past when looking at these data sets. And so you can see here, I won't dive into the numbers, but you can see we were able to very accurately identify the fragmentation of this data. And I want to credit Dr. Jenny Sun, our data scientist, for pulling this view together. She did phenomenal work to get these data sets organized and represent these results as I'm about to show them to you. But this fragmentation picture, to me, speaks volumes about the challenge ahead of us in interoperability in this country. And so I am told, because I work with this data every day, and so I had expected results like I just showed you, but I am told by those in the know, and I'll let Rishi and Anjum comment on this as well, that we were able to get a data set that's much more dense, more data dense in the biomarkers, in the data that's typically only available in EHR systems. You can see here serum creatinines, more than 60% of the population, pretty reliably. Hemoglobin A1Cs, EGFRs, of course, race, ethnicity, gender, available on everybody at one point in time or another. You can see a whole host of other data points there. And then, things like BMI, blood pressures, and so forth available in this data set. So with that, I'm going to wrap it up, and hopefully we have time for questions, and we can scroll back through or forward through slides as needed.
Okay, thank you, David, and thank you, Anjum, for this excellent set of presentations. It's very, very helpful to kind of see how the HIE infrastructure has grown and kind of end it with this real use case, which is very reflective of many descriptive studies that we do in Sentinel. So very, very useful, very helpful representation there. And David, to your last comments, I think these numbers that you were showing with 60% plus coverage of some of these kidney functioning and stuff like that, they seem like gold to us, because we typically work with these large tertiary care systems like the MGB, for example, where the care fragmentation that you describe is actually, we see it firsthand in the data. And so the numbers that we see there are unfortunately much lower. And so this is excellent. Of course, there are challenges in putting this together, but you have made a great head start. And so we are really pleased to see these results coming together. So thank you for presenting them. So with this, I will note that this session is open for question and answers. And please feel free to type your questions in the Q&A. Your lines are muted. So we have started receiving some questions. I think there was one question which was, I guess Anjum answered it already, but there's another question that just came in. Are there specific EHR which gives you better information than others? Any comments on that, David? Are you ready to declare winners there?
There are definitely better and worse EHR vendors in terms of their ability to have interoperable data, but also the quality of the data that they send. And it's not who you would think. I will just say that. Some of the most prolific, prominent vendors have among the worst or most pernicious problems with the structure of their data and the completeness of it. And I will also acknowledge that each of those vendors are subject to the implementation plans and tuning that each of the clinical sites does with their systems. So I will say that there's definitely more variability within vendors than across multiple instances of the same vendor's platform. Does that make sense? So EHR vendor A and B are going to be much more different than instance 1, 2, or 3 of EHR vendor A. And I think that's something that is important to note, because the nation's entire quality measurement enterprise is depending on this same data as well for deploying value-based payment models, for doing public health alerting, et cetera. And so because we brought this data to rest and can see the data quality picture in one place, I think it makes puts us in a unique position.
Great. There's a second question that came in from Rich Platt. Do you think that the case example that you were showing, oral hypoglycemic one, the EHR, the patients you find in EHR but not in claims are representing self-pay or something else? And have you evaluated patient-level correspondence between EHR-based prescribing and claims dispensing? So I know, David, you have an answer for this.
So what I will say is this. We are probably the most aware of boundary conditions of anybody, because we see that in our data. So I represented 3 health plans there. Oklahoma has we are a Medicaid expansion state, I'm happy to say. And so our uninsured numbers are lower than they've been in the past, but we still have maybe 8, 9, 10% uninsured. And so they are represented there, certainly, and are a cohort worth looking at separately for, access reasons and availability of these expensive, as we know, drugs. But also there are health plans we just don't have participating or sending us the data yet. So, we try to be as clear as I showed you about, what's the truth of overlap, and also where we have to say we don't know. Because missing data.
Yeah. So there is one more comment. Sounds like some of the EHRs are too expensive practicing physicians. Any specific EHRs which are more specialty centric? So I don't know if you have any comment on that, but it doesn't seem like a question.
I think that maybe shopping for an EHR. I will say that I will observe this: about 20% of organizations in our network change EHR vendors every year. So it's about the same churn as people changing health insurance, ironically. I don't know if there's some cosmic metric that links those two together, but I will say that we are in a bit of a challenge in this country, because there are fewer and fewer options, it seems, for EHR vendors. And there are some questions about the ability to innovate and compete in a shrinking marketplace as that.
Yeah. So there's
to some extent, if I can add also, to some extent, that the needs for specialty care sometimes are so unique that it also leads to more fragmentation because you need to develop better systems directly for those. And you either have to then compromise on what you can get in a more, generic or broader EHR versus what you can get for specialty care. So I think that's another issue that even we have seen within large health systems, different specialty departments using different types of data that they collect, and therefore standardizing it across even one healthcare system becomes a challenge. So that's where these HDUs and HIEs have a huge role to play in order to, because we would never be able to, I think, get away with having these differentiators in terms of as specialties become more complicated in terms of the data and the tests that they are coming up with for being more patient-centric. I think there'll be more fragmentation. So you always thought of EHRs as a layer of collecting data, but then you have to create a layer on top of it that interconnects it and normalizes it into systems.
Yeah, thanks, Anjum. So there was another question about the proportion of people in your example, David, that has both claims and EHR available, and I think we can say 25 to 30% across the three plans. And a similar question about do you know any other well-organized HIEs like yourself, without naming names in the US that are of similar or even larger size?
Oh yeah, there are plenty larger than us. We all have sort of a basic, I'm going to say a floor of functionality that we all offer. Like Anjum was talking about USCDI, which is the floor of data we should have. We don't get USCDI level data from every EHR vendor, so we take what we can get. But we all generally do some of the similar things. One, governance and trust maintenance with our communities, primary importance. Two, master person indexes. So we resolve identities and are able to link records across multiple systems to a single common chart. And then, of course, taking in data according to the prescribed standards and offering it back according to the prescribed standards are the key functionalities. And then beyond that, we innovate. Almost all of us provide real-time alerting, or daily at least alerting, to admissions, discharges, and transfers. Many of us support quality measurement. And there's a large and growing group of us that are engaged in meaningfully with organizations and universities and research and the generation of new knowledge as well.
Yeah, excellent. Thank you. I think this is a similar question. Do you play any role in accelerating approval for prior authorization requests, given that all the data are in the same place?
Not at the moment directly, although we have in the past done a 270, 271 interface with a large health plan. And that learned a lot from that experience. And what I would say is the primary way we support that, and this will apply to most health information exchange or health data utility organizations, is that we can make that provider portal available to approvers and health plans if that's a use case that your network supports, so that they themselves can, don't give them fish, give them a fishing pole, right? So that they can identify the necessary information for approvals and ideally remove some burden from the providers. However, we have been giving some thought to, especially with some of the great tools that AI is bringing us, being able to, what's the term, fight fire with fire, I guess. I mean, AI is prominently used in generating lots of communications and paperwork around prior auths today. Can we use AI to help, especially with a data set like this, to help remove or address those automatically as well?
Yeah, great points. So one interesting question came in. So this is about claims data. So claims data are not, of course, for research purposes, but EHR are likely closer to the ground truth, at least as the care is delivered. But this person is wondering from using the EHR data that it's highly likely this signal to noise ratio in EHR is actually much higher than claims. So what is your opinion about or experience about this, and how do you envision sifting through large volumes of EHR data to make it more useful and less noisy?
Right. So I will acknowledge, I mean, that even part of the reason I think my fellow providers and even me in many cases don't take the time to look for outside data when we're taking care of somebody is because we're already overwhelmed by what's in front of us now. There might be 10, 15,000 data points in the EHR I've got in front of me, and I can tell you we have hundreds of thousands of data points on each individual once you go to the network level. And so it's really an imperative now that we've begun to aggregate this data together to figure out ways to analyze it and present it in such a way that the right, fit for purpose support for decisions that need to be made, presentation is available. And so signal to noise ratio I will take to mean I have to look through 500 data points to find the one that I want, right? An important step we've taken as networks is to not deal in documents, but to deal in data points, right? So rather than having to look in 15 different documents to find the most recent hemoglobin A1C in my health and the other health data utilities, I simply look at the main list of lab results, because it's going to be there already digested and sorted for me. So I think, again, I have a chart from another talk where I talk about AI in particular and the distinct and unique opportunity that having health data utilities offer us. Anjum and his team's great paper in New England Journal talks about this as well, but I will observe that we've almost run out of internet to train models on. If you've looked at what GPT-4 and 5 coming have been trained on, it's most of the internet. And unfortunately, 20 to 30% of that is fake, is false. And the context is difficult to understand. However, the data sets we have are objectively gathered with date timestamps on them. They're date time series, right? Now, there's some context to understand, but if we, and this has been done by other groups, if we were training models on ICD-10 codes and date timestamps and LOINC codes and date timestamps and so on in the full context of the patient, then we have the ability, I think, in a credible way to have almost a patient record that I can have a conversation with, to find out what is most important. And I've actually demonstrated this using de-identified chart with GPT, and it's very possible to have that conversation.
And again, just to add that I think one of the things that we say in informatics is that the best way to improve the quality of the data and to reduce that noise to signal ratio is for that data to be used. So I think that's something that will transform the way that we are doing this, because cleaning up data or at least improving signals is for a particular purpose. You can't just go about cleaning up data, for the sake of it. So because there's so much data being generated in healthcare. So that's why I think what we are trying to promote nationally is also more use cases where these resources can be used for answering questions, for surveillance research and other kinds of studies.
Yeah, that's a great point, Anjum, as well. So there are no open questions, and we still have a couple of minutes left, so I will use my privilege as a moderator to ask one question to you, David. So in your ideal world, in the next 5 years, as you see the HIs continue to mature, what is your vision for achieving scalability nationwide? What in an ideal world, what would you like to see in the next 5 years with the HIs?
So I think we're really at a crossroads as a nation, where we're going to make the decision about whether we value community level sort of utility type structure for handling our data and applying policies and rules, or we're going to push that down into the individual clinics and hospitals. Personally, I think that would be a mistake. Because it adds yet more burden to the provider community and more liability and so forth, whereas networks like the health data utilities are built for that purpose. Furthermore, federal agencies, as in this case, or even other use cases like public health and so on, really need a single common interface point to, rather than having to keep up with, say, the 600,000 or 900,000 or 2 million different clinical endpoints that might exist, right? I mentioned fast healthcare interoperability resources as a common data model, a common data structure that is incredibly powerful and very scalable. But if there's still 1.5 million different places that we have to connect to get the data, we really haven't made any improvements. However, if because we have these health data utilities in existence, we can reduce that number to, say, 55 to 75 different endpoints, that's very manageable. And especially if we can know through something like the patient-centered data home model that if this person lives or this group of people live in Oklahoma, I've only got one endpoint I've got to query because the data is coming back to that endpoint no matter where they got their care. And so I think that I would like to see this infrastructure, which is sustained at a fraction of the cost of all the other modes of interoperability, just a fraction of the cost, and honors states' rights, honors the ability of communities, states, and even sovereign tribal systems to make their own rules about data use. I really think that that's the future where we need to go. And I will further add, it's really an imperative. As a nation, we're one of the few that don't have a centralized single-payer health system. And all of those other nations around the world have a readily available data set, not just for improving care of their populations, as was shown in the most recent Commonwealth Fund report that has us ranked last once again, but also for the generation of new knowledge, for innovation. If we want to stay at the forefront in research and in service to our citizenry, we're going to have this infrastructure in place.
Yeah, I cannot agree more with you there, David. So that's a really great thought to end this. I again wanted to take this time to thank both of you for sharing your knowledge, your expertise, and I'm sure this is not the last time we are going to talk about this. So we'll continue to monitor your progress and hopefully contribute to it in some way. So with that, we close this session today. As I mentioned, the website for the video posting is sentinelinitiative.org, which is also where we post about our new webinars. So feel free to visit that and join us in the future. So thank you all for dialing in, and especially to David and Anjum for a really exciting session.
Thank you.
Thank you.